Good afternoon. The present study is inspired by dentistry. The idea of gravity-driven DCG came to me when I was getting my teeth scan done by cone beam computed tomography, a CT scan dedicated to dentistry. Persistent epiphora with patent syringing is a diagnostic dilemma. We have various modalities available. FDT is unreliable. DCG, CT DCG, MR DCG are non-physiological, needs injection of dye, and because of poor anatomical details, scintigraphy is also not helpful. With this background, we designed this study to compare CBCT DCG with conventional DCG and to evaluate its role in patients of persistent epiphora with patent syringing. 198 eyes were randomly divided into two groups. While in one group, dye was injected in inferior canaliculus, in the other group, dye was instilled. I repeat, dye was instilled into conjunctival cul-de-sac, and the scan was taken after 3 minutes, and if needed, after 15 and 30 minutes. This is the CBCT. Patients remain seated upright comfortably, blinks normally. The dye is instilled in conjunctival cul-de-sac, and the machine takes 13 seconds to complete the scanning. The CBCT images were further classified into 3 groups: patent group, where dye was noticed in inferior meatus after 3 minutes; in delayed patency group, where dye was noticed after 15 or 30 minutes; and mechanical obstruction, where dye was not noticed even after 30 minutes. In conventional DCG, patent and mechanical obstruction group. All the images were analyzed by me and dental radiologist. As with any other CT imaging, CBCT provides coronal section, sagittal section, axial section, and reconstructed 3D view. Here are the coronal sections at different level of same patient, showing dye in canaliculus, sac, nasolacrimal duct, and even in the last image, in the tip of nasolacrimal duct. These are the 3D images viewed from different angles, showing canaliculus, sac, nasolacrimal duct, and even the intraosseous part after skimming. The low percentage of patent patients in CBTC group is because of the delayed patency group. Here is the case of persistent epiphora with patent syringing. Dye is visualized in lacrimal sac area after 3 minutes. And after 30 minutes, dye is visualized in inferior meatus with gross pooling of dye in lower part of nasolacrimal duct, indicating a presence of a structure at the tip. Contrary to previous understanding that the tears start flowing in spurt through anastomosis after DCR surgery, the CBCT revealed that tears first traveled up to the level of obstruction and then only started trickling through the anastomosis to middle meatus. CBCT DCG can be easily done in children without the need of GA or sedation. We have done it in a child of 3 years. Here is a case of mucosal on right side and persistent epiphora on left side. We did the conventional DCG on left side and it showed it is patent. Then we called the patient next day. We did CBCT DCG and this is what we found. After 30 minutes, dye has traveled only up to the upper level of nasolacrimal duct. And then we injected the dye and it has reached to the inferior meatus. This is the beauty of this physiological test. Just compare the anatomical details provided by CBCT and scintigraphy and the factor of cost make it superior to scintigraphy, though both the tests are physiological. Back to our original case, CBCT revealed a kinking at the junction of sac and nasorachimal duct. This kinking was responsible for persistent epiphora, and it was easily negotiated by syringing. This is the first study. It is 100% physiological, cheap, non-invasive, can be done in children, and it is very helpful in cases of persistent epiphora with patent syringing. Thank you.